So refeeding syndrome is where you have potentially fatal, uh, which it can be defined, condition which can be defined by severe electrolyte and fluid shift as a result of rapid reintroduction of nutrition after a period of inadequate intake. So for example, you had your patient who was malnourished or at a risk of undernutrition and later reintroduced feed maybe at a higher rate compared to the normal. This patient will have severe electrolyte and fluid shift. Next, we're going to do is pathophysiology. You cannot understand something unless you know its pathophysiology, especially in medicine. So what happens in refeeding symptoms? This patient was malnourished or had a risk of undernutrition, and now we have given the patient food that is. So what happens? Obviously, there will be rise of insulin. What will happen with insulin? Insulin is produced in order to return blood glucose back into the cells. Not only will insulin act on glucose, but it also increases cellular uptake of potassium, it also phosphate and magnesium. So starvation, because this patient was already a starved patient, this patient will have diamond and mineral deficiency, and it is exacerbated upon an anabolic process. Anabolic process, now we have given the patient food. So here we'll have renal reabsorption of sodium increase. This is because of insulin. So now you'll have fluid retention. From this, now we can know the clinical manifestation and the complication. So the clinical manifestation, obviously, we'll have electrolyte deficiency. As we said, we have electrolyte and fluid shifts. Already you have known why we have those. So you'll have electrolyte deficiency, that is hypophosphatemia, you'll have hypokalemia and hypomagnesemia, and also thiamine deficiency and volume overload. So the medical complication you have grouped it according to the systems. So cardiovascular, you can have heart failure, arrhythmia, peripheral edema. Respiratory, you have impaired respiratory function leading to dyspnea and respiratory failure. GI, you'll have constipation, diarrhea, and elevated LFTs. The muscular system, you have impaired contractility, myalgia, tetanus, and rhabdomyolysis. Neurological, you have tremor, paresthesia, delirium, and seizures. So the next, we are going to talk about, so what are the risk factors and how do we manage this? The risk factors, obviously, is reduced intake, where you have a prolonged fasting or low energy. So this includes marasmus, or where you have your surgical patient who has dysphagia, especially in stroke patients, esophageal cancer, etc., or a patient with high stress patient and who is unfed for greater than 7 days, patient with anorexic, depression, and chronic alcohol use. So this is reduced intake. These are the factors. So reduced absorption, I malabsorptive syndrome, so IBD, chronic pancreatitis, short gut syndrome, increased metabolic demands, for example, post-op patient, oncology patient, and lowered physiological reserve, so in elderly patient and controlled DM, among others. So how do you prevent and manage? Number one is for you to identify the risk. So the patient's identification of high risk patients, that is greater than 2, they have more than 2 of the following: whether they have a BMI of less than 18.5, an intentional less, as we talked about, that is less than greater than 10%, or in the past 3 to 6 months. Also, you can include an intentional weight loss of greater than 5% in 1 month, little or no nutrition intake for greater than 5 days, history of alcohol misuse, drug history, i.e. Insulin, chemotherapy, antacids, diuretics, nutritional replacement commencement after correction of electrolyte abnormalities, vitamin supplementation. So this is how you treat, so you treat by replenish nutrition commencement after. So you don't give the nutritional replacement before you give electrolyte correction. So you first correct the electrolyte and then later give the nutritional supplements. Then you also vitamin supplementation started with refeeding and continued for at least 10 days. The NICE guidelines, refeeding is started at no more than 50% of estimated energy requirements. The rate can be increased if no refeeding problem detected clinically or biochemically.